any of our colleagues wants to take the first case, these are communications. He's welcomed or she is welcomed. You can write on the chat box, please. Or if you doctors are welcomed, just please write on the chat box. Anyone wants to take the case. Bismillah. Yes, hello doctors, do you hear me? If any doctor want to practice the case, doctor, let me tell you something, doctor. If you are shy to start the case, if you are feeling that you will be stressed here, be sure that the stress inside the exam will be 10-fold. So try to train yourself on this situations. Because in the exam, actually, you'll be more and more stressed. And there are lots of psychological traps the examiners that they made already, just to know whether you are a professional or just doing things like this. So any of our physicians or any of our colleagues want to start the case, want to take the case, I will write the case on the chat box so that you can, okay. Bismillah. So this is Mrs. Look at the chat, the board, please, doctors. This is Mrs. Walter Kelly. She is a 45-year-old lady. She's having past history of valve replacement. Okay. Now, she's recently diagnosed as atrial fibrillation. It's paroxysmal atrial fibrillation. She is referred to you to discuss your task. You are the senior house officer in cardiology department, and your task is to discuss the management plan with her. Okay. Any of our dear colleagues want to take this case? You can see that we are 22, that's a good number. Hello, doctors. Okay, Dr. Hanan. Sorry, I saw her on the first. Oh, sorry, Dr. Hanan. I will unmute you. Welcome, Dr. Hanan. So, prepare yourself, Dr. Hanan. You're having a few moments just to start.
حمودي أحمد عشان عندي محاضرة.
Yes, doctor, you are ready?
Yes, doctor.
Okay, go on. Start it.
Doctor, this is my first time to present the case.
It's okay, doctor, okay. Go on.
Okay. Hello, good afternoon.
Afternoon.
I am Dr. Osman, one of the doctor in the cardiac clinic today. Am I speaking to Ms. Porter Kelly?
Yes, that's me.
Are you 45 years?
Yes, Dr. Ryan.
Nice to meet you.
Nice to meet you. Thank you.
Ms. Kelly, we are here to discuss some issue related to your health status. Ms. Kelly, you want anyone to attend our discussion?
No, doctor, it's okay. I can manage.
Okay. What do you know about your health status?
You mean the recent health status, doctor?
Yes.
Yes, for the last 1 week, I started to have racing of my heartbeats. This is the first time I feel like this. I sought medical advice. I went to my GP. He did this tracing of my heart rate, of my heart, and he told me that I'm having a condition called AFib. And then after 1 hour, he told me that my heart rhythm was back to normal without anything, just spontaneously. And then he told me that he will arrange a meeting for me with you.
Yes. What is your expectation about your health status?
Expectation? I don't know, doctor. I'm not feeling anything bad now. I'm in a very good condition. I don't feel any bad thing. I don't know. I cannot see any problem with me.
Okay, that's okay. Miss Kelly, you, as you know that your heart racing is not normal. That's why the doctor refer you to me. You have a condition known as atrial fibrillation, not be bothered by this name. It is a medical term for a medical condition in which the heart ring that is responsible for heart racing is affected, so that your heart is not beat normal as regularly as in other people. It the beat of the heart, it is disturbed. What is called atrial fibrillation. That is what you are feeling with heart racing. You may feel also shortness of breath and so. And this condition has sometimes has bad effects that it may affect, it may shoot an impulse to any part of your body that may lead you to be bedridden. For this reason, we want to give you a treatment known as warfarin or anticoagulant. Are you know anything about this?
I heard before about warfarin, doctor. Yes, but I didn't use it.
You don't know anything about this. You want me to explain you about it?
I used it once only, doctor, when I had replacement of my valve, but now I'm not using it anymore.
Okay. Ms. Kelly, this drug was used in your condition so as to prevent your this drug is a thinning drug. The effect of this drug to make your blood thin so as not to make any clot. But this drug has some bad effect, and this bad effect will not occur in any people. This bad effect that may lead to bleeding in your brain or in any other part of your body if it is not well controlled. The most important thing that you have to control it regularly, and you need a test regularly for the safety level of this drug. Is that okay with you?
So you mean that I should start on this medication?
Yes, Ms. Kelly.
Okay.
You have any problem in starting this medication, Ms. Kelly?
Because, doctor, I'm afraid of something. I heard that before one of my, the mother of my friend, she was using a medication like this. I'm not sure if it is warfarin or other medication. I'm not sure. But, she had a bleed inside her brain, It was very serious for her and lead to this permanent weakness of her left side, as I remember, if I'm not well remembering, but yes, it led to bleed inside her brain. So I'm afraid of such bleed.
I am sorry for what has happened to your friend, Ms. Kelly, but I want to assure you that this side effect, yes, it may happen, but it is it occurs. It's a very low percentage to occur, and if you control your blood level by doing the test regularly and to be combined with your medicine, this effect will not occur, or if it occurs, it has a very low percentage to occur. Is that okay with you?
So how can I know that I will be protected from such brain bleed? You know, it's very serious, doctor.
Yes, it is serious. Yes, you are right. Skilly, there is no safety guarantee that this will not happen. But as I said to you before, you have to be strict to your medicine and to the test that related to this medicine, which is known as INR, will be done by a certain lab to do this for you regularly.
Okay, doctor. So I need to follow up as well.
Yes. Ms. Kelly, what is your job?
I'm a secretary.
Okay. Is this affect your job?
No, doctor, I'm feeling very well. I don't feel anything now, you know. I'm feeling I'm very healthy.
Okay, that is good. Are you drinking alcohol?
Alcohol occasionally.
Okay. It is best to decrease the amount of alcohol that you are drinking. Are you a cigarette smoker?
No, doctor, I don't like even the smell of cigarette. I don't like it.
Okay. Skilly, as you know, you have been troubled by this problem in heart, and we've sent you to a certain doctor, and he now we prescribe you this medicine so that to be regular with it. What do you get from our discussion today?
I got that I had abnormal heart rhythm, and now you are going to start me on a new medication. It's called warfarin. Yes.
Yes.
And it can cause some bleed.
Yes, as I see you, and we can prevent this bleeding, as I said to you, and I will give you some version and website to read more about this medicine, so that to prevent any bad effect of this complication. And if you need any other support, I will give you my contact number in hospital. You have no any problem to contact me at any time. Oh, is that okay?
Okay, doctor.
You have any other concern, Ms. Kelly?
Yes, doctor, I'm having another concern. What if I did not take this medicine? You said it may cause bleed. What if I do not take it?
If you okay, that's a good question from you. If you didn't take this medicine, the blood thinning in your blood thinning have problem that will make a clot, and this clot will affect any part of your body that will people become paralyzed, as you said. What happened to your friend? So that our job that to prevent this to occur.
So if I took the medication, I may have a bleed and paralyzed. And if I didn't take the medication, I may have a clot and may be paralyzed.
Not like this. We hope that all this will not occur, and we are doing our best for your health, so that we want from you to be stick to your medicine and to your investigation. So we hope that this bad effect will not occur. Is
Okay,
that okay with you? Okay.
Okay.
You have any other thing to any other concern, Ms. Kelly?
No, doctor, I don't have any other concern, but usually I don't like medicines. You know why? Because I am, I'm working as a secretary. I'm having travels every week, every 2 weeks. I'm traveling to different countries, So I don't like medicines. I'm not sure how to.
Yes, yes, Ms. Kelly, I appreciate what you are saying. But for the interest of your health, you have to be strict to this medicine, and I will inform the social worker and the health occupation service so that to make a facility for you to do your investigation to take you easily as part of your duty.
Okay.
Okay. Any other thing you want to know?
No, doctor. Thank you.
Thank you, Ms. Okay. Okay, thank you, Ms. Kelly.
Thank you, doctor.
Okay. As I said, don't hesitate to contact me, and I will give you this my contact number in hospital, and will give you some website and try to read more about this.
Okay.
Okay, thank you.
Thank you. Two minutes remaining.
I think I finished. Nothing to add.
Okay, so we'll stop here. Okay. Okay, doctor. What is the good thing that you did in this case, and what is the non-good things? In other words, if you are to repeat this case again, what are the
Yes.
things you want to avoid in talking to the patient, and what are the things that you need to tell her again?
Me, I think I use some jargon.
Some jargons, okay. Like what, for example, if you remember?
Clock, embolus.
Okay, that's good. Okay, doctor. Why you want to start here on anticoagulation?
To prevent complication of atrial fibrillation.
So all patients with atrial fibrillation are indicated to anticoagulation?
No.
How can you decide if she needs anticoagulation or no?
If she has valvular lesion, she needs anticoagulation. If it is a lone atrial fibrillation or for any other benign cause, no need.
So do you think that she is having valvular atrial fibrillation?
Yes.
Based on what?
This is my mistake. Yes, I have not to assume something.
Okay, so I'm asking you based on what? You said that she is having valve replacement. Based on what? Did you ask her which valve?
No.
Did you ask her tissue valve or mechanical valve?
No.
Did you ask her if she is having hypertension, diabetes? Okay. Doctor, so you know the score that we decide the need for anticoagulation upon it or no?
Yeah, we will chat first, and we'll see how much she get.
What's your chat VASC score?
For this, her age is 65. She is a female, but I didn't ask her if she is diabetic or not.
Okay, doctor. So this patient, why indicated to oral? Time finished, doctor. Okay, this is a good start, Dr. Sorry, Dr. Samah. This is a good start. Okay, I will annotate the things that has been made mistake in this station. For sure, in the beginning, we are stressed. We don't know how to deal with the things. Okay, so again, please, doctors, if you are taking a case in the station 5, this is sorry, station 4. This is the resting station. The 5 minutes before this station, These are the resting station for you. So you will not write so much things. Outside station 4, you will receive a plain paper like this. So in outside, you have to divide it like this. Medical issue, as we said before, ethical issue, and legal issue. These are the 3 issues that you will meet in station 4. Not all the 3 issues should be present in all cases. You can find only 1, you can find 2, and sometimes you will find the 3, and sometimes you will find the 3 and additional issues with them. So before entering the station, you should decide what will you do inside, because inside you may be plugged. So this patient, they give you a history outside. So she is a 45-year-old lady. She had valve replacement before, okay? Now she is having paroxysmal atrial fibrillation. My task is to discuss the management plan for her. I will come back to this point. Ethical issue, you know, it will be autonomy. You can write them here before entering, and if you don't want, it's up to you. The legal issue, no legal issue here. So we'll face medical and ethical issues, but you should write this in any station 4 scenario you are going to, so as not to miss anything. Come back to this patient. Now, I'm having 5 minutes outside. I will face inside a 45-year-old lady. She had valve replacement and she had paroxysmal atrial fibrillation. So my management plan inside will be one of the 2 things, because they told me that my task is to discuss the management plan. As we know, pharmacological and non-pharmacological. This is for the medication. But before this, we have to know that she is having new atrial fibrillation. So the scenario here will be about explaining diagnosis and then explaining treatment and also explaining investigations if needed. For sure, Dr. Samah, you will not, you should have offered the echo for this patient with valve replacement. Now she is having atrial fibrillation. You will not offer echo for her. You will not offer ECG for her. You will not offer just this Holter for her. It should be done, okay? So patients came to you with atrial fibrillation. This what I will write outside before entering. I have to explain the diagnosis, I have to explain the investigations, and I have to explain the management plan. Pharmacological, non-pharmacological, follow-up, okay? Special precautions. This is a female. You will start her on warfarin, and she is in the childbearing period. Okay, so this is what I will write outside. So from the pharmacological point of view, I will start here on warfarin or any anticoagulation, okay? So what should I do inside? What will decide the management plan, the CHADS VASC score? Doctor, you should write this outside before entering, okay? So the CHAD for heart failure, H for hypertension, A for age, I have the age from here, D for diabetes, V for vascular problems before, including MI. By the way, doctors, MI. A, don't forget, age less than 65, and S for stroke. So what I want you to do inside, so this is your plan. This is what you will write outside before entering the station. Now, before entering the station, you have to decide what I need to ask about inside. I should ask about if she is having a heart failure or no, symptoms. I should ask, this is not a history station, by the way, doctor, but to explain the management plan, you need to take history from here. So the rule is not to take history in station 4, except if it is related to your issue. And here, the history is very relevant to my scenario, because I need to know if she is having any heart failure symptoms, if she is having hypertension, if she is having diabetes, if she had a stroke before or no, okay, if she had any vascular problem before or no, because these things will decide if she will be started on anticoagulation or no. Then, if she scored more than one, so this is an indication, whether it is male or female. The latest guidelines, doctors, now, you need to start anticoagulation in non-valvular atrial fibrillation, if the score is more than 1. I mean 2 or above. This is for non-valvular atrial fibrillation. Okay? But see here in the scenario, this patient had valve replacement. What's meant by valvular atrial fibrillation, doctors? This is very important. Very important. The valvular atrial fibrillation means that the patient is having rheumatic heart disease or prosthetic heart valve mechanical. Okay, doctor? Or replacement, or mitral valve repair. This is what's meant by atrial fibrillation. If you open the European guidelines, or even if you open the NICE guidelines, they will be, there is no unified diagnosis for valvular atrial fibrillation, but this is the most common definition. Valvular atrial fibrillation, rheumatic heart disease, prosthetic, I mean mechanical. The last is mitral valve repair. So what I need to ask yourself, I will ask this patient, whether she is having, I will ask here, why did you replace this valve? She will tell you for a rheumatic heart disease, doctor. Which valve? She will tell you aortic valve. It was tissue or tissue valve or mechanical valve, if you remember. She will tell you tissue valve. So this is non-valvular atrial fibrillation. So non-valvular atrial fibrillation. Come to the next step. What is the next step? Doctors, I will remove these drawings, okay? To write it here so as no one to forget. What I will do in this scenario, hello, Mrs. Kelly. Good morning. I'm Dr. Samah, one of the senior house officer today in the heart clinic. I received the letter from your GP saying that you are having a problem. Are you Mrs. Sorry, I forgot to make sure about the patient. Okay, you are Mrs. Kelly. You are a 45-year-old. Yes, welcome, Mrs. Finney. Here you should make a report with the patient. Please, doctors, don't make a report. Your report will give you mark. And the report is a very simple sentence. You will tell her, I hope that you didn't wait so much for me today. Or I hope that the traffic outside was not so crowded. She will smile and tell you, it's okay, doctor. Okay, Mrs. Kelly, we are here today to discuss your condition. As I received the letter from your GP that you are having a problem in your heart rhythm. Can you please tell me more what you know about your condition? Then she will start talking to you. Yes, doctor, you told me that I'm having this AFib because I felt some racing of my heartbeats, but after that I felt I'm okay completely. So here comes your words. The first, make empathy and sympathy. And this was a very good thing for you, Dr. Samah. You are showing empathy and sympathy. The other thing, you are checking understanding every 2 or 3 phrases. And this is very good, checking understanding. Doctor, please don't be talkative inside station 4. Be patient-centered. Be patient-centered. Don't talk for more than 2 minutes continuously. If you did so, marks will be deducted from you. So the first thing you will tell her, I'm so sorry for what happened to Mrs. Kelly. But if you would like me to discuss some things with you, she will tell you, okay, doctor, would like me to explain what's meant by AFib and start drawing for her, doctor. Or if you don't want to draw, you can share with your hands. The upper hands are pumping and the lower, the atrium and the lower pumps are pumping as a ventricle. Or even you can draw for here inside the exam. You will have a paper and a pen. Take 1 second, doctors, please, 1 second. Sorry, doctors, I am with you. Doctors, you can hear me now? Just write on the chat box, doctors, if you can hear me now. Hello. Assalamu alaikum, doctors. You hear me? Any doctor? Okay. Okay. So till here, I'm going to explain to you what's meant by atrial fibrillation. So I'm not a good drawer, but see, if this is our chamber of the heart, and these are the lower chambers of the heart, start drawing like this. Okay. The blood comes out from here to here directly. This chamber should contract. Don't say atrium and ventricle. Say you are having upper chamber and lower chambers. The upper chamber is contracting and the blood goes down to the lower chamber. This is what happens normally. In your condition, the upper chamber is not working well. In itself, it is not a big problem. It's not a big issue. But the issue is that if this is not working, if this is not contracting well, it will not push the blood down as needed. And some blood may stay here in a specific place and start to make a clot. This is the big problem, Mrs. Kelly. Because if this, by the time, at any time, we cannot expect at what time this clot can move from here down to the lower chamber and then to any blood channel. Don't say blood conduit in UK, please, doctors. Nothing called blood conduit, it's called bloody channel. To the bloody channel and then travel to any area of your body. If it traveled, it's a disaster. I'm so sorry to tell you this, but it will be a disaster because it can travel to any organ. It can travel to the brain, can travel to the kidneys, it can travel to your legs, and even it can travel to the heart itself. And if it traveled, it will occlude the distal, the blood channels at the end. So we have to give a medication to prevent this blood clot from formation. But before prescribing this medication, I need to ask you a few questions, please, because it will determine whether you will need this medication or not. So if you would, till here you are understanding Mrs. Kelly? She will tell you, as Dr. Ahmed's understanding. Okay, I would like to explain to you more, but I'd like to ask you some questions, as I told you, because the starting this medication will depend upon this. Okay, doctor, go on. So, Mrs. Kelly, do you have any heart failure before or severe shortness of breath that prevents you from doing your usual exercises? No, doctor. Then ask here, are you hypertensive or high blood pressure? No, doctor. Your age, the age, خلاص. Then, do you have any uncontrolled blood sugar before? No. By the way, I'm so sorry for this. I need to check your blood sugar again. If not tested recently, this is very good, very important point. You know, if the examiner, if you ask it here and she told you she is not diabetic, till here, okay, I will check again for you. This is a very good thing, and the examiner will mark you well for this. Because yes, she is not diabetic, you know, doctors, because patients with diabetes, if we discover the patient with diabetes today, he is diabetic for the last 1 year and he doesn't know. Most of diabetic patients are diagnosed after having diabetes maybe 1 year, okay? So till here, did you have any problem in the blood channels to your heart before, or any heart attack before? No. Did you have any blood clot in your legs before? You are asking about peripheral arterial diseases, okay? The examiner will understand this. No. Then Chadvask, did you have any stroke before? She will tell you no, doctor. Now, this patient found to be diabetic, okay? And she is having valve, but her valve is not mechanical. So doctor, if you faced a valve in station 2, in station 4, or station 5, you know, mostly they will write to you outside this patient had valve replacement. So you have to ask 3 questions about any valve. Sorry, 4 questions. The first, why did they replace your valve? Did you have a bug over it, or you have rheumatic heart disease? This is why. Number 2, which valve? Oh, sorry, doctor. I'm sorry. I'm in 1 second. Sorry, doctors, I'm with you. Okay, so if you face the valve in any station, you should ask, why did they replace the valve? And even in your life, doctor, okay? Number 2, which valve? Aortic or mitral, or both? Then, which type? Please write down these things too. Which type? Tissue valve or mechanical valve? The patient the patient know which type of the valve he had. For example, he will tell you mechanical mitral. Okay? But these are not jargons, by the way. The last thing, are you using warfarin? If he said, yes, doctor, I'm using warfarin, what is the dose of warfarin? When was the last time did you check for INR? Please write down this, doctor. If you found any person had valve replacement, ask him why, which valve, which type, and the last INR. Sorry, are you using warfarin or no? If it is warfarin, yes. So what is the dose and what was the last time INR checked? Okay. So now this lady is having non-valvular atrial fibrillation. Why? Because the replacement was for the aortic valve and it was tissue valve. If you ask me in the scenario, I will tell you it was aortic and aortic tissue. So again, what's meant by valvular atrial fibrillation? If it is rheumatic mitral, especially the mitral stenosis, rheumatic mitral, or mitral valve repair, or mechanical prosthesis, whether aortic or mitral. Okay. Then the next thing you will tell here, okay, now Mrs. Kelly, I told you that from the history you gave me, you should be started on this on a blood thinning medication. If you want me to explain to you, we have 2 options for blood thinning medications. We are having the warfarin, which most of people know, and you told me that you have idea about this, and the other thing called new drugs, or sorry, new medications, new drugs or new medications. Then you have to explain to here what are the advantages of each medication and the disadvantages of each medication. So the advantages of warfarin, it can be followed up with INR. This is an advantage and a disadvantage at the same time. It's advantage because if you find it high, we can decrease the dose, we can lower the dose, but the new medications, we don't follow them up with the blood test, which is called INR. We don't follow. The bad thing that the patient has to come every 3 weeks or every 1 month to check for his INR. Number 2, the bleeding risk here is high. Bleeding risk is high. Here the bleeding risk is lower. Stroke prevention, here better than warfarin. Okay. Okay, Mrs. Kelly. Now I told you that this is that we have 2 options, either this or this. But before deciding, I need to ask you a question. Are you planning to have family recently? Doctor, this is a lady. Please, if you are prescribing the medication to a female, you should ask her about pregnancy. Very important, very important. Warfarin in a dose more than 5 milligrams is teratogenic. Okay, so I need to ask you if you are planning to have a baby. Yes, doctor, I'm planning. I started a new relationship recently, or I am married recently, and me and my husband are planning to start. To have a baby. Okay, Mrs. Kenny, good that you told me. So at this moment, I have to add another arm here, which is the low molecular weight heparin. If you are planning to start pregnancy, I have to tell you the new medications are not tested till now in pregnancy, and we don't have any evidence whether it will affect your baby or no. So this type of medications will not give you. So we are having two options, either warfarin or injections. If we injected you with this medication, it should be given under the skin twice daily. We will train you well how to use it. Okay, the warfarin, we are having a limit. We are having a limit, maximum 5 milligrams. If it is exceeding 5 milligrams, I'm so sorry to tell you that we should shift to the injections all over the pregnancy. And at the time of the delivery, we are having another plan how to deal with your problem. At this point, she will tell you, no, doctor, see, doctor, I will not have a pregnancy, no. I will think about it later. I don't like injections, I don't want. I know, see, doctor, don't ask the patient why. The patient told you something, don't tell him why. Why carries the accent of as if you are accusing him or accusing her. Tell her, I know that you are having your special reasons for this, but can you please tell me why? Can you please tell me what are your reasons to be afraid from this? This is the same as why, but in a sympathetic manner. Okay, doctor, I'm afraid of injections. You know, I don't like the needles. Okay, Mrs. Kelly, I appreciate your concern, but you know, the needles are very, very fine. Even they looks like, you know, they looks like the hair. You will not feel the its function. It's very, very small and very short. You know the insulin needles? Did you saw anyone that with insulin before taking insulin? She will tell you, yes, doctor. It's like the insulin needles, very tight. No, doctor, I don't like it. Okay, Mrs. Kelly, it's up to you. So you told me that you will think again about pregnancy. So we are here between either new doctors. I'm talking not in a rapid way. I'm taking more time because you know I'm doing the scenario, the surrogate, and the candidate at the same time. No, doctor, I don't want this. I want either warfarin or the new medications. I'll think about pregnancy later on. Okay, at this time, Mrs. Kelly, I have to tell you have to choose either this or this. I told you the advantages and the benefits. No, doctor, I will not choose. You are the doctor. Better to choose to me. Here, you will not be blamed if you put here in a choice between warfarin and the new medication because you gave here the advantages and disadvantages. Okay, doctor, I don't like to come to the hospital every 1 month. I have my jobs. I'm working as a secretary. I want to take this medication. Okay, I will prescribe to you this medication, whether new medication or warfarin. Or if she chose warfarin, doctor, so here comes the issues. You have to explain well about warfarin, and the explanation of warfarin is not uncommon, by the way, in your life and in the pieces. So when counseling about warfarin, the first thing till here, this is the most important. Okay, before talking about warfarin, Mrs. Kelly, please, please, please don't take any medication except after going back to your GB or contacting us. Please don't take any medication. Even the over-the-counter medications, please don't take any medications. Please don't take any herbal medications except after going back to the GB or us. Because these medications may lower the effect of warfarin or exaggerate the effect of warfarin. So please go back to us again before taking any medication. The other thing, the diet. Please decrease the vegetables as possible. Vegetables, why, doctor? I'm a vegetarian. I'm so sorry to tell you this, but you know the vegetables containing vitamin K. And the warfarin acts through stopping the action of vitamin K. So if you kept taking vitamin K in vegetables, you know, the problem here that you will be having more vitamin K and the effect of warfarin will be reduced. But doctor, I cannot stop eating vegetables. Don't worry about this. Till now, please don't take the green vegetables, and I will arrange a meeting with you with the dietitian. We are having a dietitian clinic here to tell you what will be beneficial for you from the vegetables. So don't worry about this. Then you are prescribing a medication. You should very rapidly tell the benefit of the medication, advantage, and we talked about advantage, and then come to the disadvantages, and we said it, and then come to the side effects. See, Mrs. Jenny, I will tell you something. Mrs. Kelly, it's expected to have some bruises in your skin, or minor bleeds from your nose, or minor bleeds from your gums. This is acceptable. This is acceptable, except if large bruises, if uncontrolled bleed from your nose or uncontrolled bleed from your gum. At this time, you should come to the hospital immediately. But you know, minor bleeds or minor bruises in your skin is expected with the use of warfarin, and it doesn't mean that you are having a big problem, except if it is large, as I told you, and except if it is uncontrolled. Doctor, don't worry. If you repeated the important information for more than one time, don't worry. This is an important information, okay? Then, you told her about bleeding, you told her here about bruises, then you told her about don't take any over-the-counter medications. The good thing that you did also, Dr. Samah, you told her to decrease the alcohol. Here can come the question from the examiner will tell you which amount of alcohol is acceptable for those patients. Tell him, sir, see, I'd like to stop alcohol completely because it's affecting most of the organs, liver, brain, blood vessels, heart, everything. But if she insists, I will tell her that don't consume more than 2 units per day. Don't consume more than 2 units per day, okay? Despite doctors, and I am saying this outside of basis, recent trials done showed that there is nothing called as a safe limit of using alcohol. Alcohol is very dangerous, okay? So till now we explained everything. Come to the next point, which is, do you have any hobbies, Mrs. Kelly? Yes, doctor. I'm a kickboxer. I like to play Kung Fu, Karate, and such things. Okay. This is a good hobby, by the way, Mrs. Kelly. But I'm so sorry to tell you this. If you are practicing if you are practicing a hobby that will carry high risk of hitting your head, like football, like tennis, like rugby, like kickboxing, Kung Fu, such things, if your head become hit at any time, you are at a risk of having bleeding inside your brain, and it will be very dangerous. So I'd like you, if you are having other hobbies, you can do them. If you are practicing, for example, swimming, running, jogging, cardio exercises, you can do them, but please try to avoid the hobbies or the sports that your head are at risk of being hit. Till now, is it okay with this with you, Mrs. Kelly? Okay, doctor, it's okay. So now can you please tell me more? Tell me what did you get from this? Okay, doctor. So I have racing of my heartbeat. I had this atrial fibrillation. It can cause clot, and clot can travel to anywhere. And you told me that according to a specific score or something like this, I need to take warfarin, and I shouldn't take any medications except after coming back to you, and I shouldn't eat more vegetables, and I should avoid playing kickboxing, which I like. Also, you told me to decrease the alcohol intake. Yes. Okay, Mrs. Kelly. Do you have concern? Any other concern for me? No, doctor. Thank you. Okay. The thing that I want you, please, if you are planning to start pregnancy, you have to come to us again, and then we will arrange the things for you. We will calculate everything for you again and see whether you will continue on warfarin or continue on other medication. I will give you appointment with the heart physician as well, and will book you for an imaging to your heart and tracing of your heart with him. I will provide you with brochures and websites to know more about your condition. Is it okay with you, Mrs. Kelly? Yes, doctor. Is there anything I forgot to ask about? No. Do you have any concern? Raise your voice when you are saying concern. Do you have any concern? No, doctor. Is it okay with you? Yes. Thank you, Mrs. Jenny. Nice to meet you today. Thank you very much. Thank you, doctor. Okay. Now, doctors, we finished this case. Please don't forget asking if you face the case of this valve. You should ask about why, which INR, why did you replace it? Which valve, mechanical, mitral or aortic, and which type, tissue or mitral, and then ask about INR. Okay, doctor, this case finished. If you have any question about this case, just please raise your hand. If you don't have, we can start the next case. If any of our dear colleagues wants to ask about anything for this case, okay. If valve is, yes, doctor, see, mechanical aortic valve, he will continue. If the valve is aortic valve, he should continue. If mechanical aortic or mechanical mitral, he should continue on warfarin lifelong. Okay, to consider whether it is valvular or not valvular atrial fibrillation, it will not make a difference. It will not make a difference because the word valvular or non-valvular atrial fibrillation, this is to choose whether you will start warfarin or novel oral anticoagulants, because the novel oral anticoagulants are not used in valvular atrial fibrillation. Here, your patient with mechanical aortic valve, he must not use novel oral anticoagulants. He is already on warfarin lifelong. Okay? So the definition of, I told you, if you open the European Society guidelines, definition about the valvular atrial fibrillation is still no clear consensus about it. No clear consensus. Okay, Dr. Perea, did you get my point? So if the patient is having prosthetic aortic valve, it doesn't matter whether it is atrial fibrillation or no. Okay. Sorry, Dr. Mahi is asking, is there past history taken in station 4? Again, doctor, you can take history in station 4 if it is related to your case. For example, this patient came with atrial fibrillation. You have to calculate the Chad-Vasquez score for here. How to calculate the Chad-Vasquez score? They brought this case for you to calculate the Chad-Vasquez score. You cannot calculate the Chad-Vasquez score without taking a history from the patient. How to know that she is diabetic? How to know that she is hypertensive? Okay. How to know that she is valvular or non-valvular atrial fibrillation? It should be taken from the history. How to know that she had a stroke? You can. They didn't give you in the paper outside. So again, the rule is not to take history in station 4 except if it is related to your condition. Okay? Is it clear, Dr. Wahi? Okay. Okay, doctors, everything is clear now. Can we move to the next case? Any of our colleagues interested to take the case, he can or she can raise the hand. Hello, doctors. Can you hear my voice? I can. Oh, Prina. Okay, Dr. Prina, please raise your hand, please. Raise your hand to unmute you. Okay, I will unmute you, Dr. Prina.
I'm using this for the first time. I'm not sure how to
raise my hand. Dr. Prina, I unmuted you now. Okay.
Can you hear me now?
Yes, I can hear you.
That's okay. Good. Thank you.
Welcome.
Oh, by the way, my name is Ankit, and I'm using my wife's laptop, so that's my name.
No problem. It's okay. Your name is Ankit. Okay. Yeah. Okay. Welcome, Dr. Ankit.
Thank you.
So this case also, it's a communication case.
Okay.
So Mrs. Keith, she is
Mrs.
Keith, yes, 71-year-old lady.
Mm-hmm.
She came with collapse and then shifted to the hospital, mechanically ventilated. And her CT showed that she is having massive intracranial bleed.
All right.
She did not receive any sedation since admission. Sorry.
Okay.
Okay. So, since the admission and showing no signs of recovery.
All right.
Okay.
Mm-hmm.
Two consultants have confirmed brainstem death.
All right.
Your task to discuss with her daughter, Mrs. Azilina. Okay, doctor. You have 5 minutes to prepare your case.
Can I start early?
Okay, it's up to you. Okay. Yes, Dr. God.
Hello, Mrs. Azalina. My name is Dr. Ankit, and I'm one of the medical doctors, registrars here. And I'm here to discuss about your mom. Can you just confirm your name, please? Her name, please.
Yes, my mom is Mrs. Keith.
And you are her daughter. So what do you know about your mom's condition, Mrs. Azalina?
You know, doctor, my mom was walking around with her dog, and then she fall. She had head injury. I didn't see here, but this was what it was told by my neighbor. She fall, and then they transferred her immediately to the hospital, and now they are telling me that two consultants were checking if she is dead or no. I'm afraid, doctor, what's happening?
All right, I'm really sorry about the entire situation, as Mrs. Azalina. But yes, I have to bring you up to date with what has happened. So as soon as your mom collapsed, she was brought to the hospital. She was provided the breathing support, and a machine is helping her breathe right now. And we have been observing her since then. We did an imaging, that is, we did a scan of her brain, and it showed a large size bleed, which is not a very good news. We are still providing her the breathing support in the ICU, and we have been assessing her for any signs of improvement from her brain's point of view. Are you with me so far, Mrs. Azalina?
Yes, doctor, I'm with you.
Yes, unfortunately, Mrs. Azalina, we have two different consultants and on different point of times have examined her, and she has not shown any improvement, any meaningful improvement. Her brainstem, that is the basic function which allows us to breathe, which allows our heart to function, and which involves basic reflexes, things that protects us and keep us breathing, are not actually functioning very well. And as a result of which, it is the machine that is keeping her breathing. And if we happen to stop the machine currently, she will probably not breathe on herself. Do you understand what I mean?
What do you mean, doctor?
So, Mrs. Azalina, your mom is not shown any signs of improvement during her stay. And as a result of which, the chances of having a meaningful recovery is very, very, very slim. And her brain is not functioning at all.
So?
As a result of which, we don't see a lot of point in continuing this treatment, because her brain is not expected to recover from this point. I also want to add that since the time she came in, she has not received any form of sedative drugs or medicines to keep her asleep. And yet she has not shown any functioning of the brain, which is one of the most vital organs, unfortunately, to work. And it has taken a massive hit because of this bleeding in her brain.
But she was okay, doctor. She was very well. She was very well last night when I left here.
I understand. When you left the unit, I'm sorry. Can you tell me what do you know about that, please?
I don't know anything. My mom was very well. She doesn't have any medical problem before. Now you are telling me that she doesn't know any signs of recovery. What do you mean by this?
So, Mrs. Azalina, brain is one of the most vital organs that controls the functioning of almost everything in the body. And because of the bleeding, the injury that has happened to the brain because of the bleeding, it is unlikely that it is going to make any meaningful
Doctor, please, you are keeping saying the same words. She is not recovering. She is not recovering. She is not recovering. Doctor, I'm anxious now. What do you mean?
I'm sorry, Mrs. Azalina. It is what you are thinking here, that since she's not likely to show any signs of recovery, and she has been seen by two different consultants at different point of times, we are only subjecting her to, we are only prolonging this condition by providing her the breathing support. And at some point of time, we have to reach a decision, Mrs. Azalina, to stop this support and let nature take its course. Well, I cannot be sure what will happen once we stop the breathing support, Mrs. Zina, but it is very likely that she will not be able to breathe for herself adequately. And if we stop breathing, we eventually do go away.
But yeah, doctor, see, I saw her just moving up and down. How can you see that she is not breathing?
Unfortunately, that's what it is, Mrs. Azalina. The bleeding has caused such a big damage to her body. And sometimes these things do happen because of various reasons. She was unfortunate to have this. It was unfortunate that she had this.
Yes, doctor, but I told you I saw her chest moving up and down. It means that she is taking her breath. Why you are saying that she is having problem in her breathing despite she can breathe.
So at present, your mom, Kath, is connected to a breathing machine, which is helping her breathe, which is why you can see her chest moving up and down. Once we stop that, I'm not sure what will happen, but eventually she's unlikely to breathe for herself. It is the machine which is helping her breathe.
So,
So do you understand where we are going here? We are just prolonging her duration, prolonging the course of this illness, and we know that the likely outcome of this thing is not going to be very favorable for Kath. We will obviously, after we discontinue the breathing support, we'll still be watching throughout for any signs of recovery. And if we see any signs of functioning of brain, a meaningful brain functioning, we will be going back on the full support. But as of now, the consensus of the consultants is that we withdraw the support and let nature take its course.
so you want to stop the machine, doctor, yes?
That's what the plan is, Mrs. Azilina.
Cannot we try more and more, doctor? Can we live here more on this? She may recover. I know she's having a good health, was having good health before.
I understand what your concerns, Mrs. Azalina, but we have had her there are at two different points of time she has been examined, and based on the past clinical history and medical, uh, because of the kind of bleeding that she has suffered, it is quite common that these patients don't make it at all. The chances of meaningful recovery is very, very minimal.
So you mean, no problem. So doctor, you mean that you will stop the machines, and then, you said that she is depending on the machine, and if you stop the machine, she will be suffocated.
We will as of now she's not feeling anything, because usually if an awake person is subjected to a breathing support, the patient requires sleepy medicines to keep them comfortable. But we are keeping a constant watch on her. She's not needing any medicines to keep her comfortable or asleep, because her brain can not feel the discomfort, and this is because of the large bleeding she's had inside. So she will not be feeling any suffering during this withdrawal of support. We will of course be watching her for any signs of discomfort, and we will provide her the needful medicines to keep her comfortable throughout this if needed.
Oh my God.
I'm sorry, Mrs. Azalina, can I help you with a cup of water?
Yes, please. Thank you.
Mm-hmm.
So, doctor, what will happen next? I want to take care.
Sorry.
I want to take care, doctor.
I mean, you're more than welcome to sit with her if you think
I
you
want
can.
to take care to prepare things for the funerals. I want to take care.
We will facilitate it, but obviously that will only happen once we withdraw the course and we make sure that she's comfortable and we can move along that track once she's passed away. I understand what you're saying, Mrs. Azalina.
So, doctor, you mean she is suffering now, yes?
She's not suffering. She's not requiring any medicines to decrease the suffering. She cannot probably feel anything because of the bleeding that has happened in the brain. Our nurses are working round the clock, keeping a close eye on her for any signs of suffering that needs to be.
But doctor, if you stop this machine, she will not suffer. Are you sure, doctor?
We will watch out for that, but because of the injury, it is unlikely that she's going to feel anything, because her brain is not shown any sign of function.
Okay, doctor. Okay.
So we'll just go through again what we have discussed so far, Mrs. Azalina. Your mom, she's had a major bleed. She has been seen by different consultants, and she's not shown any signs of functioning of brain. We have been providing her breathing support. which is what is keeping her alive for now. And based on the multiple doctors that has seen her, we are deciding that we should be withdrawing the treatment because it is unlikely that she's going to show any meaningful recovery from here on, and let nature takes its course. We'll obviously be keeping a close eye on her for any signs of suffering, and we'll keep her comfortable throughout this. And if there is any change of plans during the course of this management, we will keep you posted.
Okay, doctor. Okay. So you are expecting to remove this machine at what time?
I will have a word with the ICU team and get back to you about this.
So that after this I can take her, yes? For the funeral.
After we confirm that she's no more, yes.
That what?
After we have confirmed that she's passed away.
So she didn't pass away till now?
I mean, her heart is still functioning, but once she stops breathing, it is the heart that will also stop functioning, and that is when we can say that she's passed away. As of now, it is a brain which is not functioning, which is the vital organ. So we can call her that she's brain dead. We will also be calling our organ donation nurses who will be interested to see if she's a potential patient for organ donation.
What do you say, doctor?
Has Mrs. Keth
organ donation? What do you mean by this?
I'm sorry, I just skipped a step, Mrs. Azalina. Has Mrs. Keth ever spoken to you about organ donation in the past?
Yes, she did discuss something like this with me before.
And what was her view about it?
I think that she is carrying an organ donation card, but I'm not sure, but I'm not accepting such thing.
Oh, but if she carries an organ donation card, we need to respect her wishes, don't you think so, Mrs. Azalina?
Doctor, there is so many. Okay, what do you say?
If she's carrying an organ donor card, we should be respecting her wishes. Don't you think that's appropriate, Mrs. Azalina? Your mom's wishes.
You think that it's not appropriate to ask about my mother?
You said that she's carrying an organ donor card, which means she wanted to donate her organ if she has potential to it after she's dead.
No, doctor, I will not allow you to make cuts in my mom's. You want to take her organs?
What I can do, Mrs. Azalina, is I can arrange
there is so much noise.
I'm sorry about the noise. What I can do, Mrs. Azalina, is I can arrange a meeting with our organ donation specialist nurse, and she can facilitate this discussion with you. Do you think that's all right?
Time, doctor. Time. Okay.
Is it okay if I arrange a meeting?
Time.
We can call her right now, and she'll get to you when she's available.
Doctor, time finished. Time. Okay.
Oh, thank you.
Okay, doctor. So, what do you think that you made wrong in this case?
I felt I had a good discussion about the clinical condition of her mom. I managed to convince her that she has a non-functioning brain and she's unlikely to have any form of meaningful outcome. So we are withdrawing the care. And she seemed to have agreed with the idea because she was talking about her funeral plans. I did not get a lot of time to discuss about the organ donation. And in our trust, actually, we let the organ donation nurse to do that discussion because the primary team should not be discussing that topic.
Okay.
So that is why I wanted to involve the organ donation nurse and let her have this discussion instead of me doing it, me having this discussion with her.
Okay, doctor, did you read your task before starting this scenario?
Yes.
Did they ask you to discuss organ donation with her?
No.
Oh, so why you are discussing organ donation with her?
Oh, actually, it came in the chat box. I thought it came from you, that she's already dead, discuss organ donation.
Okay.
I thought it was from your end. I'm sorry about that.
It's okay. So, doctor, what are the preconditions for diagnosis of brainstem death?
She has a known pathology which is causing her to be unconscious, and she has not required any sedation. She's not showing any brainstem signs, which has been confirmed by 2 different consultants. So there is an irreversible injury in place, and confirmation of the same by two different consultants. So they have seen for various reflexes, the brainstem reflexes, like the gag reflex, the corneal reflex, the vestibular reflexes.
Okay.
These are negative. An image proven called etiology is known, and that's about it. No effort, no breathing effort, and we can also confirm it by using the blood gases, that is by continuously oxygenating her through the endotracheal tube while keeping an eye on her oxygenation.
So blood gases is a criteria for brainstem death.
One of the criteria, yes.
Okay, what else, doctor, you know about brainstem death? How can you announce brainstem death?
It has to be confirmed by 2 different consultants, 2 different doctors, one of which has to be a consultant. Okay. At different point of times.
Okay.
And that's about it.
Okay, doctor. So if this patient, she told you just had this this brain injury yesterday. When to say that the patient in a permanent vegetative state?
So the devastating brain injury pathway suggests that the patient should ideally be monitored for any time frame between 24 and 72 hours. And 24 to 72. This is based on a clinical decision. So ideally, she should be monitored for 24 hours. Okay. If she's able.
Thank you, doctor. Thank you.
Thank you.
Good job, doctor. Good job, doctor. Thank you. But there are some things we have to comment in this scenario.
Okay.
Number 1, as I told you, if you are going to station 4, station 4 scenario, you have to write this outside. Please, doctor, it will help you so much. Number 1, what is the medical issue? What is the ethical issue?
Okay.
And what is the legal issue? Please do it in all your scenarios.
Okay.
Okay. So the medical issue for a patient, the medical issue here will be intracranial bleed that led to brainstem death. I'm expecting myself inside the station to explain to the relative what is the brainstem and its function, and what's meant by brainstem death, and how can we say that brainstem death happened. Then the ethical issue, as we know, the 4 things: autonomy, beneficence, etc. Here comes the legal issue. The legal issue. The legal issue here may be plus or minus organ donation. Yes, it is not written outside. And when you ask it here about organ donation, you tell him immediately, I will talk to the organ donation nurse. She became very anxious when you said this and very angry. There is much more smooth ways to enter this part. The last thing, doctor, this patient had head injury yesterday. She was walking with her dog. And her neighbors say that she was slide on her head. Okay? Do you think that you will discharge the patient after announcing death without referring her to the coroner? If a patient came to you with a stroke, okay, you can discharge. I mean ischemic stroke. But this patient came with hemorrhagic stroke. Okay, what if this patient had a hit over her head by a stick, for example. Okay? So you have to make sure, I will tell you something, you can inside the scenario tell her, did anyone saw her while she was walking and sliding? So you don't think that, you think that she had a slide by herself or anything. Doctor, this patient is medically free before. She is not diabetic, not hypertensive. I mean, she does not have risk factors for intracranial bleed just by sliding. So you have to make sure. At this point, you need to tell her, I will talk to my consultant first, because I'm not sure if we should refer your mother to the coroner or no. I'm so sorry to tell you this, because she came with bleeding inside her brain and she was walking around in the street. I'm not sure. I'm not sure if someone, for example, tried to steal something, her bag or anything, and hit her. Okay, no need to tell her such details, but at least you should put in your mind. If it is ischemic stroke, go directly and finish everything. But this is a hemorrhagic stroke. Okay. Okay. So here we said that there are three main areas: medical issue, ethical issue, and legal issue. The type of the scenario here is a breaking bad news scenario. In the breaking bad news scenario, there is scheme the same as we use in any patients with this in the communication. Number one, delete the patient. Number one, sorry. Hello, identify yourself. Please, doctor, what I want you, all doctors, please, all my dear colleagues, please, starting from tomorrow morning, you have to start doing this. In your work, in your hospital, in your round, in your clinic, do it please, because inside the exam you will forget doing this. Number one, greet the patient. Number two, introduce yourself. Number three, make identity of the patient. Okay, then confirm the age of the patient. And then we will say what will happen. So please, doctor, from tomorrow morning, try to do this. Hello, good morning, I'm Dr. Hello. Hello, I'm Dr. Khalil, one of the medical doctors in the clinic. Am I talking to Mrs. Kelly? Yes. Hello, Mrs. Kelly. Are you 37-year-old? Yes, I am. Welcome, Mrs. Kelly. Doctor, please try to do it from tomorrow. Doctors who are not greeting the patients, it's a disaster. Okay, so give here. Okay, doctor, I will. The WhatsApp, please, doctors, anyone can post the WhatsApp group here, link for the doctor on the chat box. Okay, so again, what we will do here, number one, introduce yourself to the patient, greet her, make sure about her identity, then make rapport. Why you didn't make rapport? Again, rapport, doctors, it's a very simple sentence, very simple sentence. Mrs. Kelly, I hope that you didn't wait so much for me today. It's okay, doctor, no problem. I came to my mother. Then, this is a breaking bad news, doctor. Why you didn't ask her if she wants anyone to attend this meeting? Doctor, all doctors, please, put it as a rule in all station 4. Please tell all the patients in all scenarios, do you want anyone to attend this meeting with us or no? Tell Brood otherwise. Okay, so put it as a rule in all station 4. Do you want anyone to attend this meeting with us, like a friend, a relative, or a spiritual support, or a religious support? Okay, please, doctor, make it as a rule in all station 4, except tell Brood otherwise. Okay, because some scenarios does not need this. For example, explaining an investigation, explaining a medication, explaining a diagnosis. Sometimes it does not need someone to be here. So please don't forget to tell her, do you want anyone to attend this meeting with us or no? So again, hello, and we said, don't say good morning in breaking bad news scenario, and don't say how are you in breaking bad news scenario. Because if you told her how are you, you are telling me how are you? My mom is on the ventilator and you are telling me, how are you? This will be the start, and the surrogates are well trained about this. Okay? Then again, hello, Mrs. Kelly. I'm Dr. Khalid, one of the senior house officer here in the whatever in the medical department. Are you Mrs. Kelly? Yes. Doctor, did you check if she is the next of kin of Mrs. Kath? You should check this. I'm keep repeating the things from again. Hello, I'm Dr. Khalid, one of the senior house officer in the medical department. Am I talking to Mrs. Kath Kelly? Yes, doctor. Mrs. Kelly, you are the next of kin of Mrs. Kath? Yes, I am, doctor. Mrs. Kelly, I hope that you didn't wait so much for me. That's okay, doctor. Mrs. Kelly, can I sit beside you? Okay, doctor, well, you are welcome. Do you want anyone to attend this meeting with us, like a friend, a relative, or religious support? No, doctor, it's okay with me. Then tell here that we are here today to discuss the issue of your mom. Can you please tell me more? What do you know about your mom? Then she will keep saying everything for you. Okay? Then come to explanation of the medical issue. I'm so sorry for this, Mrs. Kelly. I'm feeling so sorry. I know that, Doctor, please try to change your tone. Don't be monotonous inside the station 4. You are an actor, and the surrogate an actor, and this is a film. Imagine this is a film on the theater, and they are looking to you how a good actor you are. So please, you are an actor. Change your voice tone. I'm so sorry, Mrs. Kelly. I'm so sorry to tell you this. But you know, your mom came in a bad condition, and there is some part in our brain called the brainstem. This brainstem is responsible for controlling some vital things in our body. One of them is controlling our respiration. I'm so sorry to tell you this, but I'm having a piece of bad news for you. Then keep silent for 1 second or 2 seconds. What do you mean, doctor? What happened? Then I'm so sorry. Your mom had this brainstem death. So the first you put a warning shot, then you silence for 1 second, then break the bad news. Breaking the bad news directly, doctor. Directly. You told her what's brainstem, what the function of the brainstem. Now you are telling her that the function of the brainstem is lost because it's death. Then the golden silence for 3 seconds. Maximal 5 seconds. Don't increase more than 5 seconds. Because if you kept silent more than 5 seconds, you will make her suffer more and she will be more angry. And they are well trained for this. I'm so sorry for this. Even if she is crying, so the rule don't interrupt the patient or the relative. But here, you can interrupt by saying, sorry, I'm so sorry. I feel that you are, I know that she is your mom, she is your beloved one. But you know, I'm so sorry. We try to do everything for here, but you know, some things we cannot control. Some things are bigger than what we expect. I'm sure that you can imagine what we are talking about now. How are you feeling now, Mrs. Kelly? And then she will start crying. What do you mean, doctor, by brainstem death? She is dead. I'm so sorry, but you know, I'm so sorry to tell you this, but she will not wake up again. She will not wake up again. And doctor, but I can see her chest is moving. you know, this moving is not here respiration. This is the machine that we are already putting here on. And I'm so sorry to tell you this. Now she is not getting any benefit. She is suffering now. You know, she is suffering. Two of our consultants saw her already, and they found that her brainstem is already dead. And this machine adds more and more suffer to her. Doctor, what do you mean? But doctor, her heart is still moving. I know that her heart is still moving, but for us to live, we have to have functioning brain and functioning heart. If one of them is lost, we cannot live. And if we live, we'll be suffering so much. Doctor, by the way, this is not a DNR scenario. The doctor who said DNR need to be discussed, this is not a DNR scenario. This is an end of life. This is withdrawal of treatment, not a DNR. I'm so sorry to tell you this, but we have to stop this because, you know, I'm so sorry. And you know, after withdrawing this, her heart will stop soon after. And now the medical team, now all over I'm talking, she will be crying. I'm so sorry, Mrs. Kelly. Do you want a cup of water? Do you want a tissue? Don't touch the patient. Please don't touch, sorry, the surrogate. Don't touch the surrogate, please. Don't touch him or her. Just give him a cup of water or even a tissue. Now, you know, the medical team have to turn the ventilator off. And please, please be sure that she will not suffer any distress. If we remove this, she will not suffer any distress. And please don't feel any responsibility for this discussion. Keep showing empathy and sympathy. Okay, doctor? Keep showing sympathy and empathy and give her offer to see her mother. She will keep crying. I'm so sorry for this, Mrs. Kelly. I know that this is your mother and she cannot be compensated by any person of the life, but you know, this is the truth. I have to tell you everything. I have to tell you that she is suffering now if she is on the ventilator. Doctor, you are not asking for her permission. You are telling her the medical decision in a sympathetic way. So we will remove her from the ventilator, we will remove her from the ventilator, but in a sympathetic way, okay, in a professional way. Then tell her, okay, so Mrs. Kelly, I can take you to here to have a look at here, to touch her beloved hand, and to keep another look on her here. Then she will say, okay, doctor, no problem, it's okay. Then the next is come to the legal issues. If you are suspecting that this patient may have this intracranial bleed due to any head injury, how can I know that this is only due to if he slide? And even doctor, if the examiner told you, why will you refer this patient to the coroner? Tell him, sir, I don't know what was the cause of this hemorrhagic shock. It was not mentioned in the scenario, and even it is not mentioned in the and even the patient does not know. So I don't know whether this intracranial bleed it's due to sliding on the platform or someone hit here. I don't know. Then, if you want to discuss the organ donation card in this scenario, then you have to negotiate with a better way. Don't worry, I will talk. Imagine, doctor, one, his mother is lost, his mother is dead, and now you are telling him, I will take the organs of your mother. Imagine what he will do. Imagine what he will do. Okay, Mrs. Keeley, can I ask you something? Okay, doctor, did Mrs. Kathy expressed any wish, any wills or wishes, or did she have an advance directives? Or did she discuss with you or any family members before about giving her some part from here, like an organ or something, to another one to decrease his or her suffer? See, doctor, this is the same as organ donation, but in a more sympathetic way. See, Mrs. Kelly, some people in a situation similar to you like to make a good for their beloved ones by donating their organs to some patients who are in desperate need for them. Imagine her heart is contracting for a mom, or her kidneys are supporting a young child. So imagine you can see your mother still alive, but in another way. Do you think that, okay, doctor, now you are talking to her interior. You are talking to her interior. Doctor, but you know, this will make disfigurement for her. Don't worry, we will not make any disfigurement for her. We will, if you agreed to do this good thing for your mother, I can contact the organ donation team, then they can come and have another meeting with you or with anyone you would like from your family member. No, doctor, I'm refusing. I will not accept. What if you think again? No, doctor, I'm not accepting. Okay, I can arrange another meeting with you, for you with my consultant. No, doctor, I'm not accepting. Okay, Mrs. Kelly, what if I give you time to think? No, doctor, I'm not accepting. Okay, Mrs. Kelly, what if we invited another family member to attend this meeting again with us, and we can discuss this issue with him? No, doctor, I'm accepting. I'm not accepting. Okay, Mrs. Kelly, don't worry about this. I will escalate this issue to my consultant, and will come back to you again. And at any time you want to see me, I will be here for you. Okay? Okay. Then, here comes the questions from the examiner. So the questions in this scenario from the examiner, as we asked the doctor, the doctor who was doing the case, Dr. Ankit, the questions from the examiner you are expecting. This is a case of brainstem death. So he will ask you, is there any legal definition of death? No, there is no legal definition of death. Then he will ask you, what are the preconditions? Or how can you announce the brainstem death? Please, doctors, write this down. How can you announce brainstem death? First, it should be done by two physicians. One of them, at least, should be a consultant. Okay? So one consultant plus any other physician position. Okay? This is number one. It should be done by two physicians. One of them is a consultant. And there are preconditions for diagnosis of brainstem death. These are three things. 1, 2, 3. Number one, apneic coma. Number two, irreversible brain damage. Number three, absence of reversible causes of or reversible factors of this brain damage. So these are the preconditions. We are having three preconditions: apneic coma, irreversible brain damage, and absence of any reversible cause. Okay? And if these preconditions present, I cannot announce death except after absence of these things. of these reflexes. Number one, the pupillary light reflex should be lost. The pupillary light reflex, as we know, assists the third cranial nerve, which is the midbrain. Absent corneal reflex, which assists the fifth cranial nerve, or the pons, and part of the seventh cranial nerve, which are in the pons. Okay? Absent vestibulocochlear. Vestibulo, this is for the air, sorry. Vestibulocochlear reflex. Okay? Sorry, vestibulocochlear. I said vestibulocochlear, it's called vestibulocochlear. When you are moving the head from side to side, no conjugate movement. This is a vestibulocochlear reflex, absent as well. Vestibulocochlear. So, then come to the mouth. So, two in the eye. Even you can remember this one and this one. Corneal reflex and the pupillary reflex. Then come to the mouth. Okay? Lost gag reflex and lost cough reflex. Lost gag and lost cough reflex. The last thing is absence of cranial nerve motor response to stimulation. Absence of cranial nerve motor response to stimulation. Okay? So this question will be asked by the examiner in this scenario. What do you mean by brainstem death, and how can you prove that this brainstem death happened? So doctor, it should be done by two physicians. One of them at least is a consultant. One of them is a consultant. Second and third points. Okay, I will tell you organ donation card. Are the second and the third points are the same? Second and the third? No. This is the third. You mean here, Dr. Ankit? This is the no. This is a pupillary light reflex, and this is the corneal reflex. Okay. Then this is called the vestibulocochlear reflex. It's a reflex when moving the head from side to side. They look at the eye, the movement of the eye. If you want to know it, okay. If you don't want, it's okay. Usually they don't do it. They do the pupillary light reflex, the corneal reflex, and then if they want to do the gag reflex and the cough reflex. Okay? Okay. So Dr. M.O. asked if he had organ donation card. See, doctor. This will be asked to you by the examiner. He will tell you, okay, now you discussed with the relative the organ donation, and she kept refusing. What will you do? You will tell him, so sir, I will try with her more and more. I will try to convince her more and more. Okay, I will come to you, doctor. I should try to convince her more and more. And if she refused, I will try to escalate the issue to my consultant. I will try to escalate the issue to my consultant. And if she is refusing, I can arrange another meeting with, with another family member. The examiner will tell you, but she is still refusing. Tell him, sir, I will try to convince her as possible, because this is a good thing of practicing medicine, to convince relatives. He will tell you, if she refused, what will you do? Finally, sir, I will talk to my consultant, and we may refer the case to the legal office in the hospital. Because, doctor, I will tell you something. If the patient is having an organ donation card, by law, you can take his organs. Okay? This is by law. You can take his organs. Okay? Is she entitled to a second opinion about withdrawal of care? Second opinion, it cannot be applied here, because it's a situation inside your hospital. Second opinion usually can happen in situations like if she wants to seek another medical opinion, you mean for a diagnosis or a treatment of the disease, okay? But seeking another opinion from another hospital, I don't know which as regard withdrawal of treatment, if he asked you, if the consultant asked you, you should tell him, I should respect my colleagues and I'm trusting them that you are doing the good job. If you want to ask an opinion, withdrawal of treatment to doctor or DNR, it's a medical decision. It's not a decision for the relative. You are just informing them. You are not taking their opinion, okay? You are not asking them to prioritize things. It's a medical decision, not a relative decision. So again, Dr. M.O., you asked about the organ donation card, and he will. So you have to tell the examiner, okay, sir, I have to convince her more and more and try. And if failed, I need to escalate the issue to my consultant. And if failed everything, I will refer the issue to the legal office in the hospital, because you, as a physician, you shouldn't make confrontation with the patient. It's not your duty to make confrontation. Try to convince him if he refused. But this, talking about legal issues will not work, for example, in cases of DVLA. You have to tell the patient that you will inform the DVLA if he refuses. But this is the last resort, okay? So as I told you, by law, if the patient is having organ donation card, you can take his organs. But this is a part of good news. This is a part of good practicing of the medicine to try to convince them, because you can, even with the law, people are still making troubles in UK despite there is a law about organ donation, but relatives of the patients still making troubles till now despite there is law. So finally, tell him I will refer the issue to the legal, but tell this to the consultant, not to the relative. Okay. I will read what's written. Are the second and third points the same? I mean, irreversible brain damage and absence of reversible cause. Third, realized is relating to absence of sedation. Okay, they are different. What's meant by irreversible brain damage? Patient had intracranial hemorrhage. Patient had brain contusion. This is called irreversible brain damage. Okay. Reversible brain damage, like, for example, hypoxia, what you mentioned, hypercarbia, electrolyte disturbance, okay? These are reversible. So if any of them is still present, so you cannot announce brainstem death. Dolcine, okay, thank you for this. Dr. Priya asking, what if the patient does not have advance or LPA and the relative is refusing for an organ donation? Does the medical team have the right to remove organs? If the patient does not have the organ donation card and the relative does not want, you cannot take. You cannot take. And if you are worried about this, don't worry to tell the examiner, I will contact the legal office on the hospital. I'm not sure about this point, but I need to ask the organ donation team, the legal issue, the legal office in the hospital. Okay. Anything unclear, doctors, in this session? Because we are at the end of our session now. CPR, no, doctor, you are telling here that I will withdraw the treatment and the heart will stop. No CPR here. This is not a DNR scenario. I mean, this is not a CPR scenario. Okay? You are telling here, can you repeat those 3 preconditions? The 3 preconditions are: number 1, apneic coma. Number 2, irreversible brain damage. Number 3, absence of reversible factors. Thank you, doctors. I was happy to meet you today. If I have time tomorrow, inshallah, we will meet again. Any questions? If you have anything, you can post. Inshallah, I will upload this session on the YouTube, inshallah. DNR CPR is implied. Yes, Dr. Prina, we told the patient already, if you noticed that I told the patient already that after stopping the ventilator, her heart will stop. Okay? We told her already inside this. So no need here to discuss the CPR and what's meant by the CPR. I told her already. She is having brainstem death. We will stop the ventilator, and soon after stopping the ventilator, her heart will stop. Did you get it, Dr. Perina? I mean this scenario. Okay, thank you, doctors. Dr. Priya, because I have to go to prayer. Okay, thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.